Hey everyone, my name is Ian Dewar. I'm lead chaplain at the Morecambe Bay Trust and lead coordinator of Bay Health Festivals. We've been running these festivals for 5-6 years now, started off very small in Lancaster, we're growing it Bay wide. The whole aim of them is to engage the people in proper debates about population health. The big challenge for our culture is not whether it's money for this or money for that, it's how we look after ourselves and realising we've got the ability to do it. But essential to that is education and knowledge. And over the years, we've discussed people of mental health, we've discussed race and healthcare, and this year we're dealing with anatomy, and we have Professor Adam Taylor with us to deal with that in a moment. Before I move on to that, a couple of other things that's really important. The whole thrust of Bay Health Festivals is it's local people committed to the local area. The three people putting this together, our filmmaker Janine, Adam, our professor, and myself, are all from Lancaster. All went to school in Lancaster, we're committed to the area, and we want these debates to go on and to encourage people to think about health and well-being. We're here before an invited audience of students from Our Lady's Catholic College and from Lancaster Royal Grammar School. We're hoping that they'll ask questions. If you are watching from this at home, you can type questions in. We have people on hand to answer those for you. So as you see this going out, got any questions, pop your questions in. It's on the Trust YouTube site and we'll try and answer those as best as possible. Next year is the 200th anniversary of the foundation of the Lancaster Medical Book Club. Now that sounds really odd. But 200 years ago, to find out our medical information, you'd write off to London, get a book sent up, may take a few weeks, you'd read it, your colleagues would read it, you'd then discuss it, you'd then say, what do I do with this patient? It's quite possible to argue that the foundation of that book club, of which we have an original copy of the first book they bought in its foundation, is the birth of modern medicine as far as Lancaster is concerned and this city and its work here. So it's great to remember that's coming up next year. It's great to be here for the Health Festival again. It's great to be discussing anatomy. And I won't talk any more at all. I'll hand it over to Adam. Adam.
Thank you, Ian. Just to echo, delighted to be here. Thank you for the invite. And it's great to have a live audience and be able to take them around a tour of what is an ox heart to start with. Okay, so just out of interest, any aspiring medics? Show of hands. Probably about half, I would say. People interested in biomedicine and those subjects? Yeah. And what about philosophy and other things? No? Okay. Yeah? Okay. So as we go through, I'm going to give as much as I can to the audience, but be mindful that we've got the camera behind us, so you'll see me rearranging a little bit. So we're going to start. This is an animal heart. This is an ox heart. Okay. So it's about half the size of a human head. And the first thing to talk about is the shape and the appearance from the outside. So I'm afraid when we get it, the butchers already do their piece to check that there's nothing that they need to report. So you can see from the outside, there's a glistening, shiny appearance, and that's perfectly normal, okay? This is the same appearance as any other muscle in the body, but this is a special type of muscle, and we'll come on and talk about that. What about this stuff here? Does anybody want to have a guess what this is on the outside? This kind of, it's hard to feel. Yeah, go on.
Guess the sort of light stuff.
Yep.
Fat or...
It's fat. And do you think that's normal or abnormal?
I'd say it's pretty normal.
It's pretty normal. So to have fat around the heart is not uncommon, okay? Everything, like everything else in the body, moderation. So we need fat around the heart. It insulates the heart, it protects the heart, and we've got a number of things on the external surface that it's there to help protect. So I'm rolling it over to the what we would call the back of the heart here. And can you see this? It almost looks like a river running down the surface. Can you see it on this side here? So this is one of our, what we call our coronary vessels. This is coronary artery. All arteries supply blood to something, and the heart's no different. It's probably the hardest working muscle in the body, and it needs a supply of blood. And this is a coronary artery running down the posterior wall of the heart. We've also got one running down the anterior wall of the heart. And as the heart beats and contracts, that fat insulates those vessels against being squished too much from the outside. At the top here, sorry, I'm just going to take this out. So this is a blood clot. It's there's a number of them in there. That's a blood clot. So if we position it from the top here, hang on. Should have brought my goggles. There we go, another blood clot. If we position it from the top here, we've got a number of openings that you can see, and I'll talk you through more of these shortly, but that's just to give you an appreciation of the outside. So if we begin our journey into the heart internally. I'm going to open it up using the slice that's already been made. Okay? There we go. The slice that's already been made. So if we look inside, we've got perfectly normal heart muscle. So the heart muscle itself is known as myocardium. Okay, this is the myocardium. This is the heart muscle. Very red because it's got a rich blood supply and lots of muscular fibres in the same way that any other muscle in the body does. Myocardium's special because it's a type of muscle that can contract on its own. So when you raise your hand, when you stand up, when you walk around, you're controlling that musculature. This myocardium has its own pacemaker. It has its own electrical circuit that causes it to contract, and that is what our heartbeat is. Okay? So as we go inside, we're going to look at the 4 chambers. The heart has 4 chambers. There's 2 atrium and 2 ventricles. The atria are at the top, and they're rather small up here. We're not inside. I'm going to open them up in just a second, but they're at the top here. The 2 chambers that we're looking at the bottom, at the moment, are the ventricles. Okay. What do you notice about the ventricles? So the one I've currently got my thumbs in at the moment, this chamber here, when we stitch it back together, that's the right ventricle. And then this larger one that I'm running my thumbs through now, when we stitch it back together, is the left ventricle. Does anybody notice the difference between the left and the right?
Left ventricle has more muscular, I guess.
It's more muscular, but what about the space as well?
I'm not really sure.
Not sure? Okay. So I can, if I close this up, I can get maybe 3 or 4 fingers into the right ventricle. If I close it up again, I can get at least most of my hand in there. The left ventricle is much larger in terms of volume compared to the right ventricle. And you're right about the, what did you say, the musculature? Yeah, absolutely right. So the left ventricle has a thicker wall. So at the bottom here, this is the thickness of the left ventricle wall. And this is the thickness of the right ventricle wall. So I would say in this here, so right ventricle thickness here, left ventricle thickness here, right here, left here. I would say the left is probably about 3 times the thickness of the right. Why? Why does the left ventricle have a much thicker muscular wall than that of the right?
It pumps blood around the whole body, whereas the other one only goes up to the lungs.
Okay, so why does it need to be thicker?
It provides that it goes at high pressure.
Why higher pressure? Why is it against the higher pressure? You're absolutely right, but these are the questions that everybody's going to want to know. So why is it against higher pressure? What?
Yeah, that's fine.
Okay. Anybody else? Yeah.
It's got to get further up and down the body, of course, so it needs a higher pressure to work against gravity.
Possibly gravity, but the other thing is, as you said, the right-hand side is just going to the lungs. The lungs are they're like a sponge, basically. We're just pushing blood, liquid into a sponge. The left-hand side, has to pump against everything in the body, all of the muscles, all of the capillary beds in those muscles. It has to pump into bone, the liver, the heart itself. And so it requires a much bigger muscle, just in the same way as the bigger your muscles in your arms and legs are, the more weight that they're able to move. So that's the right, and this is the left. So let's start our journey in the right atrium. Okay, so I've currently got my index and middle finger sat in the right atrium. Okay, so as blood comes back from round the body, it's received into the right atrium. The atria are receiving chambers in the body. So we have blood coming back through 2 holes, 2 vessels, into 2 holes into the right atrium, and I've basically got my fingers running through those 2 holes. One corresponds to what we call the inferior vena cava, which brings blood back from basically below the heart, and the other is the superior vena cava, which brings blood back from above the heart, and everything empties into this chamber, which is the right atrium. So what I'm going to do now is just open that up so you can have a look inside, okay? So we're now looking inside the right atrium. If people can't see and they want to get up and come have a closer look, they're welcome to do so. Yeah.
Other than size, is there any other difference between a human's heart and an oxen heart?
There are some very subtle differences, But for the intents and purposes of this, they're identical. They've both got 4 chambers. The distribution and thickness of the myocardium is exactly the same. They've got coronary vasculature. The arteries and veins that supply and drain the heart are exactly the same. But yeah, as far as we're concerned at the moment, only size is the big difference. So if we go back to the right atrium, into here, I can put my fingers into that atrial space now, and it passes down through an atrioventricular valve into the right ventricle. Okay, so my index finger is now poking out through that valve into the right ventricle. In the right atrium, the atria are very small, but can you see these kind of strands of string? Can you make those out? Can you see at the back there? Yeah, these kind of stringy strands that I can't quite get my finger under. Yeah? You see? So this is a special type of muscle in the right atrium, and what that helps to do is to pump the blood into the right ventricle. So it goes through the valve into the right ventricle, and we can see there are bridges of muscle. These are called trabecular carnae, muscular bridges, that jump across inside the ventricle from one side of the wall to the other. And they help, when the heart contracts, they maximise the pressure that the heart generates to pump blood out and through, out into the pulmonary artery. Okay, so from the right ventricle, if we were to close it back up, it goes from the right ventricle up into this vessel here. So this is the vessel that's taking blood away from the heart to the lungs. So it goes up from this side and comes out here to the lungs on either side, and that's the pulmonary artery, and it's quite stretchy. You can see it's got a little bit of elasticity in it. From there, blood goes to the lungs, carbon dioxide is exchanged for oxygen, and it then comes back into the left atrium. It comes through the pulmonary vein into the left atrium. So here we go, let's turn this over. So these 2 fingers are coming back through the pulmonary vein into the left atrium here. Yeah? And we're going to do the same thing. We're going to open that up and take a look inside. Any questions while I'm doing this? No? Okay. On this side, there's much more in the way of those kind of muscular strands in the left atrium compared to the one on the right, because the one on the right again isn't quite pumping against as high a pressure. If I reopen this, my fingers are currently in the left atrium, again through the atrioventricular valves and then into that big muscular chamber that is the left ventricle. It then pumps round, contracts together and pumps blood out of the left ventricle. Through which vessel? It should be the aorta, and it is. So I'm going to look at 2 things. Should be the aorta, it definitely is the aorta. I want to compare 2 things here. I don't know if you can, so let me get my hands in the right position so you can see where we're looking. There we go. I've got a finger in this vessel here and one in the aorta here. What do you notice? Just bear with me 1 second, please. What do you notice is the difference between the aorta and the wall of the aorta compared to that of the pulmonary artery here?
It's much stiffer.
Much stiffer, did you say? Yeah, okay. Which is much stiffer?
The aorta.
Okay. Can you see the thickness? So this thickness here versus this thickness here. The aorta here, pulmonary artery here. Yeah. Why does it need to be stiffer and thicker?
Because it has the pressurized blood going through it.
Yeah, so the aorta is much thicker. When that left ventricle contracts, it drives blood out through the aorta, And part of the way that the blood maintains its speed as it goes around the body is by the elastic recoil of the aorta, helping to cannon or propel the blood round the rest of the body, whereas that's not required to get it to the lungs. So that's why they're different thicknesses. Okay, so those are the major chambers of the heart and the major vessels coming off it. If we think about the heart functionally, and this is a big issue, heart disease, particularly in the Western world, in the UK, for example, the heart and heart-related... Yes?
Just going to ask before we moved on a couple of questions.
Of course.
Would you be able to put a number on how many times bigger the aorta of the sort of heart here is in the human heart?
How do you mean in terms of bigger? You mean like the diameter of it?
I'd say diameter.
This one, so the diameter of this one here of the ox is about, I would say, 3 to 3.5 centimetres. That's not actually that much bigger than what we call the ascending aorta that comes off a human heart. So the ascending aorta, it differs slightly in diameter between men and women. In men, it's about 3.1, 3.2 centimetres in diameter. In women, it's about 2.6 to 2.8. So it's not actually, in terms of diameter itself, that much different from what we look at here in an ox compared to the human heart.
And then the secondary question was about the muscles within the heart, especially the ones that jump across the heart.
Yep.
The very thin strands.
Yep.
Obviously, blood is supplied to those sort of muscles by just the blood being in the heart. But in terms of repair, how does the body know how to repair muscles like those strands?
Okay.
Broken in the heart, snap completely.
Okay, so that's a really good question. So we're just going to go back internally and talk a little bit about. So the question was about these strands here. Yeah, these trabecular carni, and their function and potential for them to snap, and how that's repaired, which is a really good question, because we only have one heart. As we know, when it goes wrong, it's usually not a particularly good good outcome. Heart health is really important. So these muscular strands actually very rarely snap. They're an integral part of the heart musculature. They're there biomechanically to maximize the efficiency of the heart when it contracts. So it would be very uncommon for these to snap. If these were to snap, other things would likely have precipitated it that would be picked up and likely cause death and disease before that happens. But in terms of repair, we're going to talk a little bit more about repair of various parts of the heart in just a few minutes, because I think it's incredibly important to look at that in the context, as Ian alluded to earlier, in kind of population health. Does that answer both your questions?
I think it will
Once we get to it. Excellent. Okay, so those trabecular carni are incredibly important. The other thing, I think, just going back to the left-hand side, which is much more muscular, is to look at this kind of structure here. So can you see it? It's almost kind of like a hot dog sticking up here. Yeah. So this is a special type of. It's got a special muscular name. This is a papillary muscle, and the papillary muscles in the ventricles provide the site of attachment for these stringy white structures. You see all of these stringy white structures here? Yeah. So these stringy white structures are known as cordae tendineae, which is basically Latin for tenderness cords or stringy cords. And these are incredibly important because when our heart contracts, it generates pressure, and blood, like any other liquid, will take the path of least resistance. It will go whichever way is easiest for movement. And so when the atria contract, they drive blood into the ventricles, and we have the valves. We have the AV valves, which are one-way valves that let the blood into the ventricles. The ventricles are much higher pressure, and when they contract, they drive blood out of the ventricles away from the heart. And what we don't want to happen is for blood to go in the wrong direction. So when these papillary muscles contract as part of the heart, they pull on these fibrous strands, on these cordae tendineae, and close the valves of the heart. Sorry, let me rephrase that. They close the valves between the atria and the ventricles to prevent backflow, because what we don't want is blood going the wrong way around the heart, because that doesn't end particularly well. So these tenderness cords, they are like tendons in the rest of the body. They don't contract. They're very tight, like your Achilles tendon, for example, and tendons attached to other muscles. And they're there to pull tight the valve leaflets, as we call them. And these are the valve leaflets here, these white, bear with me one second. These white, shiny structures. This is part of the the atrioventricular valve here on the left-hand side. Can you see this white? So they're incredibly thin. So you can, in part, see my finger through them. That's how thin they are, but they're up against incredible pressure when those ventricles contract. So for you folks on this side, my finger here is behind this valve leaflet here, also here, okay? Was that another question coming up? No, okay. So that's one of the valves, the atrioventricular valves, and that prevents blood flowing the wrong way around. So the heart is a muscle just like any other. It contracts, it needs its blood supply. And we need to talk and think a little bit about repair. So as I was saying earlier, 1 in 3 people in the Western world will die from either heart disease itself or vessel-related disease. And the reason for that is many factors, most often linked to lifestyle and damage to the heart or the vessels that sit around it. So what do we mean by damage to the heart? The heart is a high-pressure system, okay? Wherever we have high pressure, we have the potential, yes?
Weakening of the left ventricular wall.
Yeah, so we can get weakening of the left ventricular wall, which means that the heart is
Pressurized when it contracts.
and not as efficient at pumping blood round, yeah, which causes problems in terms of getting tissue to all of the blood to all of the tissues of the body. So in terms of excuse me, in terms of damage, what kind of damage are we thinking about? Well, I'm going to take you back to this here. This is blood clot. Okay, this is just red blood cells that have stopped circulating and have clotted. When we talk about blood, we often think of it as a liquid. Okay, when it's in our vessels, it's a liquid. It moves around quite happily, but it can also be a solid. Blood can also be a solid. When does it become a solid?
I would assume when it stops moving quick enough to essentially keep it in liquid form. If you keep it in one place for too long, it'll simply sit there. And
Yep.
condense.
It can become a clot like this when it doesn't move. Any other times? When else does it stop being a liquid? You've all experienced this. Everybody watching at home will have experienced this. Everybody sat in the audience.
When you get scabs.
Yeah, when you cut, when you end up with a scratch or a cut, blood leaks out. Now it doesn't look like this because this is abnormal. We wouldn't expect this to happen unless we've got some kind of disease process. But when we open vessels or we cut through the skin, we end up with normal clotting process, which forms a scab. Okay, so that's clot. And so inside the heart, we have a special lining. Okay, that's the reason in part why it's shiny. There's a special lining on all of our on the inside of all of our vessels and in our heart that keeps our blood as a liquid. Okay, and when that's damaged, that's when we begin to see clotting and damage to this special lining that keeps blood as a liquid. When that process happens, it's often lifestyle factors, for example. Anybody want to have a guess at some lifestyle factors that might contribute to damage to our vessels and our heart?
Eating unhealthily would cause like fat buildups in vessels.
So yeah, a poor diet is one of the big factors. Yeah. What else?
High cholesterol diet.
Yeah, so linked to more specifically to diet, so cholesterol in particular, yeah.
Would high blood pressure be one of them, sort of having regularly high blood pressure
Yep.
to a job? Or
Persistently high blood pressure is one. So when we've got other things that are always pop up in this context are linked to smoking, for example, and where we get increased blood pressure and too much salt in the diet is one of the key ones. Damage happens to this special lining. It happens to the lining in the heart, but more commonly, it happens to the specialized lining in our blood vessels. And you can see, hopefully, that is shiny and smooth. And over time, what happens is increased blood pressure causes that shiny, smooth layer to be chipped off. And we get the start of a clotting process happening. And that changes the composition of the tissue locally, and that leads over a number of months and years to a build-up of what we call fatty plaques. Athero or arteriosclerosis happens, and that changes how much blood the vessel can take, but also how blood flows through the vessel, and it causes further damage. So the lining of the heart and the blood vessels is incredibly important in heart health. Okay, let's think about other things that can go wrong in the context of the heart. And we were talking earlier about coronary vessels. So the coronary arteries are incredibly important. They come off the aorta and they run on the outside of the heart to supply it with blood. The heart is a muscle and we have to exercise it. It beats, normally, a normal resting heartbeat is between 60 and 100 beats per minute. It varies from person to person. Your maximum heart rate is typically 220 minus your age, which varies for everybody watching and for the audience in the room. So 220 beats per minute minus your age. So on average, when we're exercising, when we're running, we're playing sports, for example, we get up to about 180, 190 beats per minute. So that's 3 times every second your heart's beating, okay? The reason it increases is because as the heart, as we said, is a muscle, it requires more oxygen, and therefore we need to get more blood into these coronary vessels. But these coronary vessels are also susceptible to build-up and blockage, just like any other artery is. And therefore, over time, if that happens for a prolonged period of time, they can become blocked. And where we block off blood supply to the heart, that causes basically a heart attack if it happens over time, okay? So I'm just going to see if we can cut into this coronary vessel and see if we can see the thickness of it. Have a look at it in a little bit of detail. So I might flip over for the slightly thicker one, I think. Just bear with me 1 second. There we go. Okay, yeah, we've got it here. So this is one of the major coronary vessels here running in here. I've cut through it and it's wide open. But where these become blocked by a disease process, that starves or it reduces the amount of oxygen we can get into this muscle. In the same way that when we exercise, when we run, if we run long distances over a prolonged period of time, we get cramp. The heart muscle is the same. And where the heart muscle can't get enough oxygen, we get chest pain. And if that happens very suddenly, that's a heart attack. If it happens over a prolonged period of time, that's angina. And that is medically manageable.
We hope you enjoyed it so far. We've had a number of questions passed to us by members of the audience that we've realised we think are probably very important to people watching this at home, and maybe questions that you yourselves are also asking. So what we're going to do now is going to take some of those questions, allow Adam to deal with them, and then when we finish, we're going to take a short break of a minute, after which we'll then move on to talking about the impact of the pandemic on our organs, and that's clearly an important issue for many of us. There's lots of talk around about the pandemic's not over yet, there's still more COVID, and there's long COVID. So we'll take some questions first, short break, and then we'll move on to the impact of the pandemic on our organs. So, first question. Your name is?
Egaline.
Egaline. What's your question, Egaline?
I wanted to know that do the tendons in the heart ever snap?
Do the tendons in the heart ever snap, Adam?
So the tendons that we were looking at earlier, these silvery, very high tensile things, it's very rare that they would snap. It's not common. I'm not saying that they don't, because when you say things don't, people always prove you wrong. But these tendons are designed to withstand huge pressures as those ventricles contract, driving blood out. What can happen is, rather than the tendons being problematic, we can get problems with the valves that they hold on to, and that can cause regurgitation of blood, so blood not quite emptying from a chamber or flowing back into the chamber from which it's come from, and that can be problematic. So tendons rarely snap, like tendons everywhere else in the body, under incredible strain, doing an amazing job, but the things that they're attached to can often break and can often dysfunction, and those valve leaflets in particular are one area where we can have problems. So it's a great question.
Thank you. Yeah, let's take another one from this gentleman here. What was your name, sir?
Matthew.
Matthew. What's your question, Matthew?
So how is blood supplied to the muscular bridges inside the heart?
Okay, so how is blood supplied to these muscular bridges that we were looking at inside the heart? There are a number of them in various different chambers, and every heart's different. Every heart has a different number. But basically what happens is, we looked at the coronary arteries earlier, and in the break I've had a cut through some of them and isolated some on the other side. So you can see from this side here, this is where I've begun to isolate this coronary vessel. You can see that the main vessel runs down, and then small branches begin to come out of those major vessels. And as they do, they descend down into the muscular tissue itself. And within the muscular tissue, we have a number of smaller arteries. We can see a few of them in the myocardium here. There's a couple in here, for example. And within the myocardium itself, they will go into very small capillary beds that run between the muscle cells themselves and around the muscle cells, and they will run into those bridges. So there will be very, very tiny vasculature in here, as well as relying on things like diffusion of oxygen away from the vessels themselves. So that's how we get oxygen to keep those muscles functioning.
Thank you. What's your name?
Viraj. Viraj.
Viraj.
Following on from the first question, in the case that they do snap, is it possible for them to be repaired by the body, or is it permanent?
So that's a great question. So snapping of these, again, as I say, likely to be very, very rare in instances that these would snap. Repair mechanisms in the body are incredibly efficient, but there's issues with the heart. So these muscular bridges, if you think one of the things we do when we get snapping of things in the body elsewhere is we have to immobilise. Well, immobilising something that beats on a resting day 60 times a minute, long enough for it to heal, is not possible. So it's very rare that they snap, and the mechanisms by which these would be repaired would be unlikely to be able to let them repair naturally. It'd probably require, if necessary, some external intervention from a surgeon or similar to repair those. But as I say, the breaking of these bridges is incredibly uncommon. What's more likely is that they're impacted in the same way that the heart wall muscles would be from myocardial infarction, and they stop functioning due to lack of oxygen.
Yeah, happy with that answer? That's okay. Okay, we'll take one final question now. What's your name, sir?
Hamza,
Hamza. Come on, Hamza. What's your question?
why does the hole in the heart occur specifically in the heart?
Why does a hole in the heart occur specifically in the heart? I think of that not as an anatomical question, but there's a couple of footballers had hole in the heart, so from a sporting point of view, I'm interested.
Absolutely. Right. So I think it's important to recognise what happens when the heart develops. So simply it starts as a tube, and then it folds into a U-shaped tube, and then it basically divides itself into 4 cavities to give us our 4 chambers. And as that happens, we talked about the atria, the receiving chambers earlier. So here's our right atrium, and here is our left atrium on this side. I've got my hand in it behind here. And when that happens, those atria, in fetal life, when we are in utero, when we are inside our mother's uterus, we don't breathe. Our oxygen comes from mum. And basically between the right atrium and the left atrium, there is an opening, and it would be on the wall here. And that opening enables blood. So in normal circulation, we take a breath in, that oxygenated, let's start again. We'll start in the right atrium, where the deoxygenated blood comes back to the right atrium. It then gets shunted into the right ventricle. It's then pumped to the lungs where we get rid of oxygen. And then we breathe fresh oxygen in, back to the left atrium, left ventricle, round the body, back to the right atrium. In our fetal life, when we're in utero, the system is slightly different. And that's because our blood comes back from round our body, and we're attached by our umbilical cord, and our oxygenated blood comes in through our umbilical cord to the right atrium. It doesn't need to send all of that blood to the right ventricle, because we don't send it to the lungs because we're swimming in fluid, in amniotic fluid. And therefore, it's shunted through from the right atrium to the left atrium. And from the left atrium, it's then into left ventricle and around the body. And there is a flap that enables that to happen. Now, when we're born and we take our first breath, the pressure change from the right and the left-hand side. So the pressure on the left-hand side of the heart is massively increased compared to the right. When we take our first breath, that pressure forces the valve flap closed against the wall. Now, in some people, that valve flap is forced, but it doesn't quite close properly. And where that happens, blood might be able to squirt through, a tiny bit of blood might be able to squirt through. And when a doctor listens to your chest with a stethoscope, what they're listening for is the heart sounds, the opening and closing of the valves. But what they can also hear is if you have a hole in the heart, they might be able to hear the high pressure kind of sound of blood squirting through that hole. Now, in some people, the hole's quite big, and that can manifest as symptoms typically when they're born. So hole in the heart is typically when we describe the atria. One thing to flag while we're talking about that is the ventricles, those big muscular structures at the bottom of the heart. The muscle grows up in development and contacts into where the valves are situated. And some people, that growing up fails to happen, and we get left with a gap between the ventricular wall and what we call the fibrous skeleton of the heart, which is basically where the valves are. A hole in the ventricles is much more problematic because you get blood from the left-hand side that's supposed to be being pumped around the body going back to the right-hand side, and that interferes with how the oxygen gradients that we need to exchange oxygen and carbon dioxide in the body. So there's two different ways we can have a hole in the heart. A number of people may have a hole in the heart and never know about it because it's so tiny, it doesn't manifest as symptoms, it doesn't give them anything. But until we either listen to the heart or there's a reason to go inside the heart or investigate the heart, most people never know that they have a hole in the heart. The only time you would know is when you're first born, if it typically manifests as symptoms. So quite a long answer, but I hope that gives you lots of information about it.
So what you're saying is this is sophisticated plumbing, really?
Yes, very sophisticated plumbing. And plumbing that is often moving while trying to look at it and fix it.
That's fantastic. Thank you very much indeed, Adam. We've dealt with lots of questions. It's been absolutely fascinating. Our audience here are fascinated by this. We're going to move on now to the lungs and talk about the lungs, but with particular reference to the impact of the pandemic. You've all been reading papers and magazines and seeing on TV about how COVID affects our lungs and people having long COVID. So we're going to try and bring that into it. We're going to analyse the lung in the same way we analyse the heart, but at the same time, we're going to give some references to that and see if we can learn anything from that, our thoughts on that. And again, as before, we'll take ad hoc questions from the audience as we go along if they've got them. Thank you.
Thank you, Ian. So welcome back. So as Ian said, we're going to take a look at lungs. So this is from a sheep. So I think the first thing it would be useful to do for the audience watching and also in the room is orientate yourself. So on my hands at the moment, I've got what we call the trachea or the windpipe. So this is the means by which organisms bring oxygenated air into their system. We've got the heart, which we looked at the ox's heart earlier. This is still in a sac in it, which we would find in the body. The heart sits within a sac, and the only way I can describe it is keeping the heart is in a carrier bag, basically. And that's called the pericardial sac. And that sac is basically a protective bag that sits around the heart, because don't forget we said earlier the heart is beating 60, 100, 150, 180 times a minute. And as it's doing that, it's moving around, and that stops it from moving around excessively, but it also helps anchor it in place. And then on either side of that, we've got two lungs, and you can see them here, very red, full of blood and oxygen. The thing to say, just to flash, this is ever so slightly different to what we would see in a human. Don't forget we are bipedal, we walk upright, and therefore our heart sits in the middle of our lungs. In animals that move on four limbs, the heart actually sits forward. So what I'm going to do is just position this. So if the head was over to my left here, it would be like that. The heart actually hangs down in front of the lungs, and the lungs sit slightly behind like that. But I'm going to turn it back over for the view for the things we're going to look at next. So, as Ian alluded to, it's been a long 2.5 almost years now in terms of COVID. And we know that COVID is transmitted by respiratory. It's predominantly respiratory transmission. We breathe it in, the virus is in the particulates, and it gets into our body and manifests in people differently. Our respiratory system is divided into what we call the upper respiratory tract and the lower respiratory tract. And in humans, the upper respiratory tract is anything that sits above the vocal cords, what we use to make sound, and anything below that is the lower respiratory tract. So if you have an upper respiratory tract infection, it's usually above the vocal cords, lower is beneath. And that's important because of how it manifests in terms of symptoms, but also how it's treated, for example. So lungs in humans are slightly different on each side. So on the right-hand side, which is here, we have 3 lobes, a inferior or bottom lobe, a middle lobe, and then a superior or top lobe. And it's the same here in this, but also on the left-hand side, the same as in humans, we only have 2 lobes. So there's 3 lobes, bottom, middle, and top on the right, and bottom and top on the left. What I'm going to do now is open up the heart just to show you. I'm going to open up the sac that the heart sits within, and we can look in a little bit more detail at what it looks like. So I'm opening up this sac, and I'll remove it. And the thing to notice again, as with the one we looked at earlier, is the amount of fat that sits around the outside of the heart. Remember, it's an important protective material. So if I just slide it out like that, there you go. You can see, again, we've got the heart, we've got the fatty tissue. So we talk about the lungs. The lungs are incredibly important. And if I squeeze these lungs, they feel very much like a sponge, just a bath sponge that you would have at home. And the composition of the lungs is the same. Okay? When you squeeze a bath sponge and release it, it returns to its normal shape. The lungs do the same thing. If we take a bath sponge in the bath and we squeeze it in the bath, it fills with water. Okay? Ideally, in the lungs, those spaces that exist in the sponge are filled with air, and when they fill with water or liquid, that's a bad thing. Go on, we've got a question in the audience.
Talking about filling with liquid, what preventative measures do the lungs have to stop them, sort of the blood obviously getting into the air spaces? Are there any special properties to the membranes inside the lungs?
So that's a really good question. So the question from the floor is related to what mechanisms exist within the lungs to keep liquid, i.e. blood, out of the air spaces where oxygen and carbon dioxide in the air exist. And so we have a highly specialised layer, and it's a very thin layer, it's thinner than cling film, that exists as our surface, as our membrane for oxygen and gases to be exchanged over. And that keeps the blood on the vascular side, and it keeps the air on the space side of the lungs in the alveoli spaces. And that is a selective membrane, and it prevents crossover. It can be damaged. So for instance, where we get infection, and that can be bacterial or viral, that can cause the membrane to become leaky. And COVID it can be an example of where that happens. And we get movement of liquid blood into those spaces. The other example is if we end up with a bacterial infection or a viral infection of different origin, we get our immune response, and we get things like pus, for example, being produced to swamp whatever the invading organism is. And pus is another thing that we can find in those air spaces. And whenever we get liquid in there, it reduces our ability to be able to exchange as much oxygen and carbon dioxide efficiently as we typically need to.
And the secondary question would be, so you're talking about that membrane, and going back to something you said about the heart, is that it has a specific property to its membrane that keeps the blood flowing past it.
Yep.
Essentially, keeps it liquid so
yep.
that it doesn't clot within
yep.
the lungs. Does the lungs have that same sort of membrane?
Yes, so that's a really good question. So the question from the floor relates to what we spoke about earlier in terms of the heart keeping the specialised surface within the heart keeping blood as a liquid. In the capillaries within the lungs where we get gas exchange, the special lining is there exactly the same in the vessels in the lung tissue, and that lining is the same. It keeps blood as blood. It's the same in every vessel throughout the body. Wherever we have blood vessels, we have this special endothelial lining which keeps blood as a liquid and prevents it clotting. As we said earlier, sometimes that fails for lifestyle factors, for example, and we end up with clots beginning to form. And we've got a follow-up question.
In case of instances where liquids do get into the lungs, are there any surgeries or treatments that can happen to reverse the effects?
So where we do get liquids into the lungs, the body has various mechanisms to prevent liquids getting into the lungs, and that is, as we all know, when we go swimming or we drink and it goes down our trachea rather than our esophagus, we have a reflex that coughs it, that removes it. To a point in the lungs, so we all know that when we get colds and other kinds of viruses and bacteria in our respiratory system, we have a cough. That's one of the mechanisms to prevent things getting down into the lungs. But there's a specialised lining down our trachea and into the upper parts of the bronchial system that exists. And there's a special type of cell lining those airways, and they've got little hairs on them. And we've got special cells that produce mucus. So when you've got a cough or a cold and you're coughing up sputum, which is always a horrible colour, that's a protective mechanism. So everything that we've got is a means to prevent things getting into our respiratory system. That being said, there are instances where, particularly things like pneumonia, where we're particularly unwell, where we get pus and all sorts of other things collecting deep down in the lungs. Typically, if the immune system is able to function properly, they can be cleared by the immune system separately. It's incredibly difficult when you get down, going in to clear them through the respiratory system. You get to a point where you wouldn't be able to get an instrument or anything that far down into the depths of the lung tissue itself. So we typically rely on the body's cellular mechanisms to try and clear out, but often it requires medical intervention in terms of things like antibiotics, etc., to help clear that. And I hope that answers your question. Yes.
You know how they say you shouldn't drink before surgery? They tell you. Is that to do with the liquids getting into the lungs?
That's a really good question. So, disclaimer: I'm not a surgeon. This is not my area of expertise. But typically, they tell you not to consume anything because people react to the anaesthetic that they give you, particularly going under a general. They have to put you on they have to help control your breathing. What they don't want is a full stomach, is people for that to, when you lay down and when they're working, for that to empty back into your throat and then wash down into your lungs, for example. Also, when you come out the other side of surgery, people typically don't feel great, and if you feel sick, you've got something, what you don't want is to be being sick, particularly if you've got surgical wounds and you've had significant surgery. You don't want to be feeling unwell and potentially damage those as well. So there's a variety of factors, but as I say, that's not my area of expertise. Okay, so let's take a look then. So I won't focus too much on the heart. We can have a look at that later if anybody's interested. We've got the attachment of all the great vessels. It's much smaller than the one we were looking at earlier. But if we follow, what I'm going to do is follow the trachea down, and we'll look at the point where it bifurcates. So I'm just going to make a couple of incisions as I go down, just to open this up slightly more. So as you know, we've got a single trachea or single windpipe that descends down, and then at a point it splits into two. Okay. So we've just taken a quick break. So all I've done is cleaned out so we can see all of the trachea. And you can see there are kind of ridges as I run my finger down the trachea, and they carry on all the way down to this point here. And at this point here, it splits. The trachea splits into a left main bronchus and a right main bronchus to go into each of the lungs. These tracheal rings are incredibly important, and you can actually feel your own at the bottom of your windpipe, where your thyroid is. As you go just down from it, you can kind of feel one or two bulges. Don't press particularly hard, but you can just feel the little ridges as you run down. And they're really important. They're bars of cartilage that hold our trachea open. They make sure our airway stays open so that we can get oxygen in and carbon dioxide out. Now, as we go down, we see that splits, and we've had a really interesting question from the floor, and that is related to why premature babies can't breathe on their own or struggle to breathe. And there's a couple of reasons for that. One of them is when we breathe, we rely on the musculature of the thoracic wall, the muscles between the ribs and the diaphragm. And also at a very young age, babies actually use their abdominal muscles, so those muscles that form the so-called six-pack muscles. They typically use their abdomen to breathe rather than their thorax. And so part of it is to do with the development of those muscles. But the other thing is that up until about week 26, 28, their respiratory system hasn't fully developed enough. So it's usually about 38, week 40 when they're born. So it takes, in the final 10 weeks, in the last 10 weeks of their development in pregnancy, is the point where they're actually able to fully function. And the other thing is, we have a special type of cell in our lung that produces something called surfactant, which is important in really deep down in the lungs, holding the airways open, the tiny microscopic alveoli open. And that surfactant creates surface tension. That's really important in holding it open. And before that, before about 28 weeks, the cells that make that aren't yet fully functional again. So there's a combination of factors, which is why when premature babies are born, particularly before 28 weeks, they often require quite close monitoring and careful intervention in helping them breathe. Okay, so we looked at the tracheal rings as we go down, and we know that our respiratory system is how COVID is typically taken into the body. It gets deep down into the lungs, for example, and those interfaces between the airways and the capillaries are very thin, as we said before. Typically, when we get right down to the alveoli, it's only a single cell thickness between the airways and the capillaries. And on the surface of those airways is where the COVID virus binds. And it is basically a lock and key theory. The virus gets hold of the receptor and uses it to get into the bloodstream. And it is there that everything begins to happen. And one of the key things about COVID is that shortness of breath. And we get the response deep down in the lungs, whereby we begin to get our immune cells creating an inflammatory response, and that can make things worse in terms of filling some of those air spaces. But we can also end up with things like pneumonia, where we get the lung tissue being filled with pus and kind of creating that shortness of breath. So what I'm doing now is just cutting into the lung tissue, and we can have a look at the inner substance of that. So you can see that it's a mixture of kind of pink and blacks. And the pinks and blacks, the pinky orange colour is the respiratory tissue, and then the reddy black colour is the blood vessels that exist within the lung tissue. So this is what a relatively healthy lung looks like. And you can see if I squeeze that, there's still blood in there, and it comes out through those vessels. Okay, so we've got the respiratory tissue in here, and it's the same on the other side. And where we get pathologies in the lungs, where we get problems, pneumonia, COVID, etc., the lower down it is, the harder it often is to clear, because gravity takes an effect, for example. And again, you can see there's nothing coming out. These are healthy lungs. How do I know these are healthy? Because when I squeeze it, there's nothing coming out other than blood out of the vasculature. If these run healthy and I squeezed it, we'd get kind of pus and liquidy stuff coming out of the tissue, and that's not the case in here. Okay. So I'm just going to cut into this a little bit more, and what we'll do is we'll look deeper down. Any questions while I'm doing this? So when we get down in here, we can still feel
over here, Adam, I think.
Oh, sorry, yes.
Okay, no.
In the medical field, we learn that, so in the organs where people have defects or problems, in the medical field, I think they're starting to look into using stem cells to grow new organs. How successful will we see that to be, or is it successful? And if we further look at it, theoretically, is it actually doing the proper job that it should be doing?
Yeah, so the question is about stem cells being used to grow organs and how practical and likely is it to happen, and where it does happen, how good are they at doing the job, right? Yeah, so it's a great question, because that's a view that that's what we're going for in terms of trying to maximise longevity for people. Varied. There's a lot of research into stem cells. Not my area of expertise, so I can't comment. But it's ongoing. We're getting closer to being able to grow organs and their functionality. One of the biggest challenges is where they're not grown from the individual's own cells is immune response to them. We're beginning to see things like organs on chips, etc., helping to do function, helping them with their function. But we've still got a long way to go. Everybody is different, and therefore it's getting to that kind of personalised medicine that people are after is hopefully going to happen in my lifetime. But I wouldn't say for certain. Okay. So as we go down into the tracheal system, we begin to lose the cartilage rings. So we get to the point that we get deep enough down into the lungs where the cartilage rings begin to disappear. I can still feel them and see them as we get down to this point here. So as I've opened this up, I've still got cartilage rings here. I've still got some cartilage rings here, but they're beginning to disappear. And then we get to the point just down here. I can feel you can see the opening here, but they're beginning to disappear in terms of holding it open, and that's because we no longer need the mechanical structure to hold them open. Okay. So as we go down into the lungs, as I said, spongy tissue with lots of airspace where we can get gaseous exchange happening. Sat either side of the heart. In terms of the lungs themselves, the lungs are actually from a kind of immune response and protecting us from the outside world. They're interesting. Now, it's one of the few places in the body that you can see what we call the lymphatics. So the lymphatic system is incredibly important in returning excess fluid to the circulation, to the veins and the arteries, but also on the surface of the lungs, we can't see them on these, but we have lymphatic channels, and lymphatic channels are important for immune cells moving around the body, but also clearing pathogens. And in the lungs, particularly in individuals who smoke, where we squeeze the lungs, for individuals who smoke for a prolonged period of time, you can feel the tar, you can feel the substances deposited in the lungs over time. And that is reversible in some respects. The health of the lung can improve when you stop smoking. But one of the things to flag with the lungs is also, depending on where you live, depends on how healthy they are. So we have a natural amount of kind of microparticles and things that go into the lungs. And for those of us that live in leafy, green, rural Lancaster, it's very limited. We don't have a lot of diesel goods moving through the city. But in some of the bigger cities, where you breathe in particulate matter, it goes deep down into the lungs, and it goes so deep down, we were talking about clearing things out before, that we can't cough it out. It's not possible to get it out. And so what the body tries to do is clear it out another way. And we can see usually the lymphatic channels on the outside of the lungs with that carbon particulate matter as lots of little black hexagons dotted around. So the lungs are, when we look at them, when we're able to look at them, they're a good indicator of general overall respiratory health. Okay? I'm conscious of the time. Does anybody have any final burning questions that they want to look at or want to cover in relation to respiratory system?
So how do you look after your lungs then, Adam? Questions were asked before about looking after your heart and exercise and balance. I mean, how do you look at? So this lot may face great temptations to smoke or to do whatever. Tell us how you look after your lungs.
Again, it's about everything in moderation, isn't it? We there's a strong anti-smoking message, and there's no doubt that the evidence is that smoking damages the lungs. But exposure to fresh air, that's the best thing. Getting good, clean, fresh air in there. We talk about going out for a walk, doing 30 minutes brisk walking every day. That doesn't just give you overall health, but it, lung health,
right.
And minimising exposure to dusty environments and those kinds of where you're getting excessive amounts of particulate matter going in, that kind of, being sensible, wearing dust masks when we're doing DIY work and that kind of thing.
Fantastic.
All the stuff that goes with general kind of health.
Right. Thank you. By the way, that I can also use that as a plug. You do know that I've closed one of the roads in Lancaster on Sunday morning for cyclists only, coming up from the back of Sainsbury's to Dalton Square. It's only a short route. We're just trying it and see what it's like. So if you want to get good air in your lungs, bring your bike along at 9:30 on Sunday morning. Okay, between 9:30 and 12, you can cycle up to Dalton Square, listen to live music, and buy some ice cream if you like. It's entirely up to you. There we go. Thank you. Any other questions from the audience? No. Thank you very much indeed. You've actually been a really good audience. You have some very intelligent questions. We've had some good discussion coming from it. I'm really grateful for that. And you are an embodiment of what we try to do at the Health Festival, which is just engage people in conversation, in thinking, in asking, in finding out. Because one of the things I find most unnerving about our culture as a whole is we seem to have lost the ability to realise that the best person to look after yourself is you. You can go for a walk, you can, try and have a good diet, you can spend time with people, you have more power than you think to have a good, healthy life. And part of what we discussed here with Adam today is getting us to think about that at a slightly deeper level. So Adam, thank you very much indeed on behalf of myself and Bay Health Festivals. And thank you on behalf of the audience. And well, let's say thank you. There we go.
Thank you very much.